So then comes the question of the debate. So the people, those who are metabolically healthy, should they require any treatment? Or we should prioritize the treatment of metabolically unhealthy people with obesity rather than those who have metabolically healthy obesity. So therefore, that debate is still on and we don't have the answer. So as I've already said, that the health impact of the obesity, I'm not talking about the cancer, I'm not talking about osteoarthritis or talking about the increased possibility of gallstone disease, but as I've said, the 4 important organs which actually we consider endocrinologists are very important to us. One is pancreas. Few gram of fat in the pancreas is responsible for the beta cell defect and leads to the development of diabetes mellitus, or I must say one of the important reasons for the development of diabetes mellitus. The one important person, the Roy Taylor, who had done an excellent study showing that if you can reduce that few gram of fat from the pancreas, there is a reversal of the diabetes, which has been established. And now if you look into the other organs, the adipose tissue associated kidney disease, heart disease, and as you know, metabolic associated fat liver disease are quite common. So if you look into the weight loss program, if there is some degree of weight loss, then you will get some benefit. Higher the weight loss, higher is the benefit. But at least 5% weight loss is necessary to get some benefit in the state of hyperglycemia. 5 to 10% weight loss leads to improvement in the non-alcoholic fat liver disease. A 10-15% weight loss leads to the improvement of NASH hepatitis, and more than 15 or 20% weight loss leads to diabetes reversal. So therefore, any degree of weight loss is important. Higher the weight loss, higher will be the benefit. And therefore, most of the people do not want to do the lifestyle modification, and therefore they ask this, why should not take just a pill? Now, till recently, we have only few oral drugs, anti-obesity drugs available to us. Now, this is the only drug available in our country right now is the Orlistat. Very recently, the naproxen bupropion combination has been actually marketed. What I mean to say, don't look into the cosmetic effect of the obesity. How much weight loss is happening? These drugs actually cause weight loss of 5%, 8% or something like that. But we need to see whether these drugs can give benefit in the 4 important complications which I am talking about the diabetes, whether they improve the metabolic associated fat liver disease, are they good enough to prevent the cardiovascular complication of obesity? These are the important questions, not the cosmetic effect of the obesity. Now, if you look into the long-term cardiovascular outcome trial with the Orlistat therapy, though there is no dedicated cardiovascular outcome trial is there in Orlistat, but this is basically a cohort study from UK showed that it significantly improved the major adverse cardiovascular event. However, we now have basically a number of medications which can actually reduce the body weight. So liraglutide, semaglutide, dulaglutide, and these GLP-1 receptor agonists are nowadays used as an anti-obesity drug. And you can see all 3 drugs actually shown the significant benefit as far as cardiovascular event and mortality is concerned with LEADER, STEP, SUSTAIN and REWIND trial. The liraglutide and semaglutide are approved as anti-obesity drugs, but dulaglutide is not yet approved. Now we have, a few years back, we have done this study, and also looked into the all other Indian studies, and we compared the weight loss benefit with liraglutide. We have not used the liraglutide as an anti-obesity dose. We have used liraglutide as anti-diabetic dose, 0.6, 1.2, 1.8 milligram dose, and we have found that the liraglutide in Indian subset produces more weight loss, 4 kg to 6 kg in different Indian studies, including ours, compared to the lead study, which is basically Western data. So, what we understand that these GLP-1 receptor agonists actually more beneficial in Indian subcontinent as far as the weight loss is concerned. Now, if you look into liraglutide, this 3 milligram dose in the Western study, it reduces the weight loss of 8 kg, roughly around 8 kg, which actually we achieve with the liraglutide of 0.6, 1.2 or 1.8 milligram dose in our country. And if you look into the study output, is 1/3 of the patient actually achieves the 10% weight loss. Looking into semaglutide is a far better drug which we are yet to receive this with this dose, 2.4 milligram dose, you will find that the weight loss is almost 15%, 16%, 17%. So better than the liraglutide, the whatever we have. But the issue is GLP-1 receptor agonist. If we look into the meta-analysis, all the GLP-1 receptor agonists, if we consider together, they are not only associated with the cosmetic effect of the weight loss, but they are associated with benefit in all-cause mortality, major adverse cardiovascular event, composite renal outcome, and that goes without saying, it has benefit in major metabolic associated fatty liver disease as well. Now, recently we have these three drugs, tirzepatide, retatrutide, and orforglipron. I think the retatrutide and orforglipron is not yet available, but it will going to be available within near future, no doubt. So therefore, be ready for these two drugs which are going to be available. Tirzepatide is now available in our country as well. And you found in a SURMOUNT trial producing 22.5% weight loss. So what I am showing you, that the oral drug used to produce a weight loss of 5%. We have GLP-1 receptor agonists, they produce say 10%, 15% weight loss. Semaglutide is producing roughly around say 20% weight loss, 18%, 20%. Here is tirzepatide producing 22.5%. And the maximum weight loss was actually shown with triple agonist, GLP-1, GIP, and also glucagon receptor agonist, that is 24.2%. So, if we look into head-to-head between semaglutide once weekly and tirzepatide once weekly, you will find that the tirzepatide actually beaten the semaglutide even with a 5 milligram dose of tirzepatide is better than the semaglutide as far as the weight loss is concerned. However, let me tell you that the semaglutide was used as a 1 milligram dose and not as 2.4 milligram dose. But if you look into beyond the cosmetic effect of the weight loss, I can share with you that the cardiovascular outcome with semaglutide is excellent with 20% risk reduction. The cardiovascular outcome with tirzepatide is not yet available, is going to be available in 2027. The kidney outcome in the SELECT trial and tirzepatide also showed benefit in the long-term kidney outcome trial. And if you look into metabolic dysfunction associated steatohepatitis with semaglutide and tirzepatide also shown the benefit. So therefore, these drugs not only have the cosmetic effect but also have effect beyond the cosmetic problem. That means the heart, kidney, liver, as well as the diabetes mellitus. Very recently, this SURMOUNT-5 trial has been published only a few weeks back, and you can see this actually showed that the semaglutide, tirzepatide is better than the semaglutide, with a 20% reduction with tirzepatide and 13% reduction with semaglutide in a head-to-head study. So my take-home message is that the commonest cause of obesity result from calorie intake exceeding energy expenditure. People, those who are telling jol khelo mota hoy, they are wrong. People are eating and that is why they are getting obese. Number two, that the metabolically unhealthy obesity is associated with increased risk of diabetes, kidney disease, fatty liver disease, and cardiovascular event. And therefore, we should, when we are looking into any anti-obesity drug, we should not look only into the cosmetic effect of the drug. We should look beyond that, whether this drug is giving benefit in the other aspects of the obesity or not. And glycemic efficacy and weight loss with liraglutide seen in Indian studies is far more impressive than seen in lead trial. This is our own experience which we have published. And GLP-1 receptor agonists have shown significant benefit beyond glycemic control, especially in cardiovascular, renal, and hepatic outcome. And semaglutide is more effective than liraglutide in weight loss, and tirzepatide is more effective than semaglutide in weight loss. And lastly, but not the least, retatrutide is more effective than tirzepatide in weight loss. Thank you very much for your patient listening. This is my photograph in Everest Base Camp Trek. Thank you very much.
Thank you.